Our game plan for today. We're going to hit 5 key areas: positional complications, placentas, cardiac changes, twins, and finally, coagulation.
Let's kick things off with Section 1, positional complications, specifically looking at supine hypotension.
Okay, here is our first clinical scenario. We have a pregnant patient with pregnancy-induced hypertension being monitored in a supine position. What is the likely complication here? Is it ascending aorta syndrome, superior vena cava syndrome, abdominal aorta syndrome, or supine vena cava syndrome? Take a second and lock in your answer. So what's actually happening under the surface here? Well, lying completely flat, especially right around or after that 32-week mark, often causes lightheadedness. And the mechanics are pretty straightforward. You've got this heavy, gravid uterus physically pressing the major vessels right up against the spine. That pressure heavily restricts venous blood from returning to the heart. It's essentially a mechanical roadblock. This is exactly why it's absolutely crucial to tilt these patients to the left lateral position. It shifts the weight and relieves that pressure. And that brings us to the correct answer, which is D. That physical compression of the inferior vena cava by the uterus leads directly to supine vena cava syndrome, which you might also know as supine hypotension syndrome. So the big takeaway here, it's all about that mechanical obstruction reducing venous return. Moving right along to Section 2, placentas and decoding chorionicity.
For this second question, let's test your visual diagnosis skills. Take a good look at this placental image. We've got a single placental mass with 2 umbilical cords. Is this twin-to-twin transfusion syndrome, a monochorionic diamniotic pregnancy, a monochorionic monoamniotic pregnancy, or a dichorionic diamniotic pregnancy? Look closely before we break down the clues.
Let's train our eyes here. If you look at the image on the left, notice how those 2 cords are inserting right next to each other on a single shared placental mass. But the most important clue? There is absolutely no dividing membrane between them. 0. Now compare that to a diamniotic placenta on the right, where you'd easily spot a clear membranous division separating the 2 amniotic sacs. Because we don't see any dividing membrane and those cords are just hanging out together in a single shared sac where they are highly prone to getting entangled, we can confidently call this a monochorionic, monoamniotic, or MCMA pregnancy. So C is the correct answer. As you know, this specific structure requires incredibly close monitoring because of that extreme risk for cord accidents. All right, Section 3, cardiac changes, looking at what's normal versus what's pathological. This one is super interesting because a mother's heart adapts so drastically during pregnancy, and sometimes those normal changes can totally mimic serious disease. The question asks, all of these are normal physiologic cardiac changes in pregnancy except for one. We've got left axis deviation, mild ST changes in inferior leads, atrial and ventricular premature contractions, and a pansystolic murmur. Which one of these is an actual red flag?
Our source text draws some really clear boundaries for us. A left axis deviation? Completely normal. Think about it. The growing uterus is literally shoving the diaphragm and the heart upward and outward. Mild ST depression is also a perfectly normal adaptation. But murmurs are where things get a little tricky. An ejection systolic murmur, up to about a grade 2, is totally fine. It's just a functional flow murmur from all that increased blood volume. But if you start seeing an increased jugular venous pressure, marked cardiomegaly, or a diastolic or pansystolic murmur, those are massive red flags for underlying heart disease.
So, keeping those parameters in mind, D is our clear exception. A pansystolic murmur is pathological, not a normal physiological change. Being able to quickly tell the difference between a harmless, functional flow murmur and a dangerous pansystolic one is an absolutely essential clinical skill. That takes us to Section 4, twins and monochorionic risks. Let's look at how sharing a placental circulation introduces some really unique dangers. Which of the following complications is specific to monochorionic twins? Selective fetal growth restriction, polyhydramnios, twin-to-twin transfusion syndrome, or neural tube defects? We're looking for something that happens specifically because these twins are sharing a single chorion and a single blood supply. This brings up a really crucial distinction from our source material. Intrauterine growth restriction, or IUGR, is the most common complication across the board for any twin pregnancy. But the text specifically isolates a handful of conditions that are entirely exclusive to monochorionic twins. Those are TTS, TAPS, TRAP, and selective IUGR. These only happen because of the shared vascular architecture of that one single placenta. The most infamous of these is, of course, TTS. Let's break down how this cascade actually happens. First, deep vascular connections form between the twins right inside the placenta. This creates a deeply unequal blood flow. The donor twin is essentially pumping its own blood volume over to the other twin, which leads to anemia, decreased renal blood flow, and eventually oligohydramnios. On the flip side, the recipient twin gets completely overloaded, developing polycythemia, heart failure, and polyhydramnios. It's just a brutal, cascading fluid imbalance. Now, while the text does note that selective IUGR is also specific to monochorionic pregnancies, twin-to-twin transfusion syndrome is the absolute classic textbook hallmark answer for monochorionic specific complications in this context. So C is our definitive choice.
And finally, Section 5, coagulation and hematological shifts. For our last question, let's look at the blood. The pregnant body is preparing for a massive physical event, and its chemistry shifts dramatically. We know pregnancy is generally a hypercoagulable state, but look closely at these options. Factor 2, factor 7, factor 8, and factor 11. Which one of these specific factors actually drops, acting as the exception to the rule? The source provides a fantastic breakdown of this. Almost all of your clotting factors, along with serum fibrinogen, are going to increase. The body is heavily prioritizing clot formation because it wants to prevent excessive bleeding during delivery. Makes total sense, right? But there are highly specific exceptions. Factors 11 and 13 actually decrease. You'll also typically see a benign drop in platelet count, which we call gestational thrombocytopenia.
So, using a simple process of elimination, factor XI is the odd one out. It reliably drops during gestation, which makes D the correct answer. It's knowing these nuanced little exceptions that really proves you have a deep grasp of obstetric hematology. I love this quote from the text because it perfectly sums up the core theme of today's explainer. Pregnancy is a hypercoagulable state requiring highly specific adaptations. Think about that for a second. The body safely pushes its own limits, but it doesn't just do it randomly. It's executing incredibly organized, hyperspecific physiological adjustments, everything from handling vascular compression thresholds to precisely tuning individual clotting factors. Knowing the exact line between a perfectly healthy adaptation and a dangerous pathology, like spotting the difference between a harmless systolic flow murmur and a pathological pansystolic one, is literally what saves lives in this field. So I want to leave you with a thought. How are you going to apply this logic on the ward? How does knowing the why behind these multiple choice questions actually change your mindset when you walk into a complicated delivery? Thanks for hanging out with me for this deep dive in the explainer, and keep questioning the evidence.